Today, I'm being joined by Dr. Carole Gilling-Smith, who is the CEO and Medical Director of the Agora Fertility Clinic based in Brighton. And we are also being joined by Dr. Jonathan Ramsay, who is a very well-known and well-regarded urologist in the UK. Welcome to you both. So let's first of all start, if you could just tell us a little bit about what you both do and how you work together, and then we will start talking about male fertility.
Carole, go first.
So yes, I'm Carole Gilling-Smith and I'm the founder, CEO and medical director at the Agora clinic. So I'm a consultant obstetrician and gynecologist. And I first met Jonathan Ramsay when I was the IVF medical director at Chelsea and Westminster Assisted Conception Unit, where he was working as a consultant urologist. So that's sort of 22 years ago when we started to work together as gynecologist and urologist for the purpose of helping people to conceive.
Well, yes, Carole, 22 years, crikey.
Wow.
It certainly doesn't feel like
No,
that,
it doesn't.
nor, Carole, does it look like it.
I would agree, yes.
Anyway, so Chelsea Westminster was unique in that I think it was probably the first clinic, certainly the first clinic in the NHS, where men were formally recognised as deserving a separate approach, an individual approach. This happens, like so many things, slightly by accident, because we happen to be on the staff at the same time with similar interests. So at that time, I was doing male fertility urology at Chelsea Westminster and also at Hammersmith. So I was very lucky because as a consultant urologist, I was surrounded by infertility or fertility units, which is unusual because for most consultant urologists, certainly in those days, busy with urological emergencies and the whole gamut of urological conditions, we didn't get to see very many men with male infertility. Now, that was partially, of course, because those men tended to be centered around fertility units and not being seen by urologists, merely being treated with IVF and ICSI, which when it started, of course, was the greatest thing. It allowed paternity for men who otherwise would not have fathered children. But what it also did was to take those men away from general urological practice. And for those of us as senior as I, who trained before IVF and ICSI, then of course there were a few of us who had a separate interest which we had studied and had been mentored and understood a bit more about it when those men were coming to urological clinics in the 80s because there weren't IVF and ICSI units.
Do you find that a lot of patients come to you both, or especially yourself, Dr. Gilling-Smith, perhaps presuming there may be a female issue when actually the man hasn't been tested and there may be something there?
Yes, I think we're starting to get better patient education, but certainly it's taken a while for the penny to drop that half of infertility has a male factor to it. It's literally, a third is male factor alone, a third is female factor alone, and then combined factors account for the rest. So it's really important to not only for the couple to come forward, but for there to be specialists in both areas and expertise in both areas.
So for yourself, for example, at the Agora, Dr. Ramsay comes in and operates on your patients who need the male support, is that right?
Yes, I think as gynecologists, we have a good working knowledge of how to manage the male in an infertility setting. What we don't have is the real subtle nuances that can occur, the decision-making, and bringing in a consultant of Jonathan Ramsay's standing, which he comes in for regular sessions, and we have, this morning done a clinic. We have all, as gynecologists, put forward difficult cases where it's not straightforward, oh, let's do ICSI. This is really decision-making at its finest level. And some of the questions I know that you will be asking, Jonathan, are all about that finesse that comes with combining, the IVF specialty with urological expertise.
And Dr. Ramsay, causes of male infertility, what are the main reasons why men may be struggling with their fertility?
Well, crikey, we've got a perfect storm of circumstances, really. So I think now everybody accepts and acknowledges what many researchers have been saying for the last 20 years, which is that worldwide sperm counts are declining. And this conclusion, I think, became real only 3 or 4 years ago. So this is an important issue for men, important issue for couples, and it is important to understand the background. Now, this perhaps wouldn't have mattered so much were it not the case that at the same time, those seeking to be parents are starting on their journey a little later. So the benefit that might have come in years gone by from young motherhood, young eggs, starting to try to conceive in maybe the early 20s, certainly the late 20s, that advantage, that female factor advantage, is lost. Now, at the same time, the third bit of the perfect storm, of course, is our changed lifestyle. And not just that we may be mildly poisoning ourselves, but that also for the men, in their attempts to offset those lifestyle changes, they might actually be exercising so vigorously and in a way that might be counterproductive. So the sort of lifestyle that keeps men up at night, gets them up early in the morning, that plays hard and lives hard, might be compensated for by a degree of exercise which itself is counterproductive. So those three factors have come together, particularly in the last 10 years. I think you would agree, Carole.
Yes.
And men who think they're terribly fit and absolutely fine are shocked to see that they have a low sperm count. They say, but I'm terribly fit. Well, of course, they may be terribly fit, but they may be doing the wrong things. And that is against a background of having half the sperm count that their fathers had, and probably a third the sperm count that their grandfathers had.
So do you put that down to the way that people live today and, well, I don't know about more smoking, but drinking, bad eating habits, lack of sleep, all those things contributing together that people may do on a daily basis?
Yes, I think this must be the case. I mean, we all remember David Attenborough 3 years ago, who pointed out that the sea was full of plastic. And we all said, oh yeah, of course, sure. But of course it had been full of plastic for 20 years, as is most of the so-called civilized world. Processing foods, a very different diet. So I'm quite sure that the environment has had and is having a very significant effect on male fertility and probably fertility in general worldwide.
I think I would add the stress. I mean, the stress is, I'm always on, is it stress? My husband gets on the train at 5 a.m. and commutes, into town, and then he comes home, 8, 9 o'clock at night, and laptop on his legs, and mobile phone constantly there in the pocket. Could it all be that? And it's not something that's very easy to measure. It's, you can't do controlled trials, but there is no doubt that we are all now chained to our computers, to our phones, and reading emails at terribly unsocial hours. We're pressurized. There's no break, and I cannot but think that has an impact on normal, healthy sperm development, which is a 3-month process from beginning to end.
And of course, the cruel paradox is that when this stress manifests itself in an otherwise perfectly healthy individual who feels perhaps a little bit sad, then he will be taking, and I am surprised how many men I do see taking antidepressants.
Yeah.
Really?
Not a great thing.
It's really quite common, and there's no awareness that it could affect their fertility. And alongside that, you've got the stress which compounds weight gain and the waistline going up. And often you're seeing, what might be sort of middle-age spread in sort of late 40s, you're seeing that appear much younger.
Absolutely.
Much younger.
And
I
then
don't think COVID's helped anyone, has it, with eating habits and exercising less and depression, as you said, and the cold winter months, all of those things.
and and then to offset those feelings of sadness, feeling a bit tired, and then wishing to feel a little bit better, there's an awful lot of cocaine about.
Mm-hmm.
And one of the cruelest paradoxes, of course, is the young man who feels that he might want to be a little bit more muscular, a little bit more attractive. And of course, being attractive is all about having families and attracting the opposite sex. So he takes steroids. And of course, the muscle bulk goes up, and he's very pleased about this. But actually, the sperm count often goes to zero and may be difficult to recover. So there are all kinds of little hidden things that are happening. And as Carol's saying, to control a trial is virtually impossible. Research in the field of fertility and fertility treatments, other than that we know that IVF and ICSI works in a certain proportion of people, that is clear. But beyond that, it is terribly difficult to prove a cause and effect in almost anything.
We hear a lot about female fertility declining with age. How much does male fertility and sperm kind of deteriorate with age? And do you think that the repercussions of, say, women perhaps starting a family later are also seen in men as well?
Well, biologically, I think it would be very strange if the same things did not apply. Because, of course, fundamentally, this is about the inevitable deterioration of our DNA. When you go back to the fundamental issues about having a baby, making an embryo, this is about the DNA in the egg, which of course deteriorates with age, and the DNA in the sperm, which we now know does deteriorate with age. When we were just looking at semen analysis, which is terribly variable, you couldn't quite detect this. You'd see differences between men of 60 and 70 and 20 and 30. But actually, when you start looking at the DNA quality of the sperm, you see that deteriorations are occurring from a relatively early age, early 30s, mid 30s, and certainly then by 45, we are seeing a real and probably very significant deterioration in the DNA quality of the sperm.
And how does that affect things apart from fertilization? Does that mean that babies might be more prone to having, or children born might be more prone to having learning difficulties and behavioral difficulties?
Well, the answer to that is probably yes. These are very small percentage changes in such neuropsychiatric conditions, but I think they are there. Again, very difficult to study because of the many variables. So one has to take into account, of course, female age with an older father. One then has to understand what the DNA quality of his sperm was at the time of conception, and then, which all researchers find almost impossible to do, you have to follow that cohort not just for 2 years, 3 years, but 20, 30 years to determine the eventual outcome for the next generation. And that is a huge, huge research task.
Absolutely. And thinking about treatment options, if you could explain a little bit about male fertility treatment options, and also Dr. Gilling-Smith, how you work with your patients in terms of the process. So at what point would Dr. Ramsay perhaps operate on the male partner with the patients that you see, for example? And is it just surgical procedures, or are there other options that people can try prior to that?
Oh yes, I think the time when we ask Jonathan to see a patient is when we have a patient with very low sperm count or no sperm in ejaculate in their sample. When we've run some hormone tests, we've done some basic preparatory investigations, and we've decided the patient's either got an obstruction to sperm outflow in the ejaculate, or they've got what we call a non-obstruction reason. And these are the ones where we do need to get Jonathan to decide if a surgical or a non-surgical approach to getting better sperm, to getting some sperm out, is appropriate. We also have some cases where we're seeing very high DNA fragmentation levels in patients who have recurrent failed IVF cycles or recurrent miscarriages, and they're very interesting cases that Jonathan's working on. So they would go and see him.
It's really about moving a man's situation from one level to another. So the simplest, of course, is there are no sperm at all, in which case the proposition is pretty straightforward. Can one find some sperm surgically? It may be non-obstructive or obstructive, but one is moving from a position where nothing is possible to where something is possible. Then the next stage may be the man who's got very, very few sperm, as we call that cryptospermia, almost hidden. Now, the proposition there is, can we move that man from a situation in which IVF and ICSI is probably unlikely because there isn't a consistent sperm production? Can we move him into a situation where IVF with the ICSI technique will be possible? So we've gone up a notch. But then the patients that Carole's talking about, which are probably the most interesting and probably the most numerous actually, are those where, from a gynecological, from a reproductive gynecologist point of view, this is really unexplained. Unexplained in that the sperm count may be normal, and with a relatively young partner, there's no pregnancy. So there's got to be something wrong. Or indeed, where the sperm count might not be normal, but it looks perfectly adequate for IVF or ICSI, yet, as Carole's saying, there are 2 or 3 failed cycles. Now, those people, if we explore them and we investigate them, may well have correctable features. And I think this is probably the biggest area of expansion. If I look back 10 or 15 years ago, then the urologist interested in infertility really was only summoned when there were no sperm. I was a facilitator of doing a cycle. But really there was no understanding that there may be other areas where actually treatment may be very efficacious and turn a failed cycle into a successful cycle.
It's fantastic that things have developed so that those outcomes can happen, and you're seeing better success rates thanks to this. When my husband got a diagnosis of azoospermia, we faced quite a few weeks of genetic testing to understand the reason why. And I remember doing a lot of my own research thinking, I really hope that it's obstructive azoospermia so that there's more of a fix, if you like. Would you say that treating a patient with obstructive azoospermia there's more chance of retrieving sperm than non-obstructive?
Oh, absolutely. So obstructive azoospermia, almost wherever that obstruction is, will certainly result in a urologist being able to find sperm from some point in the genital tract. There are nuances though. How good is that sperm? Is it better retrieved from one particular place than from another particular place? And once again, I think the approach to this is a little bit more subtle, because now that we do have an extra test of male fertility, other than just looking at the sperm down the microscope, now that we can look at the DNA quality of the sperm, we're beginning to understand that DNA quality, and therefore the effectiveness of that sperm, if used for ICSI, does vary as to where you retrieve it from. In simple terms, how long has the poor little chap been beating his head against the obstruction? Because if you imagine a queue of sperm like a traffic jam, the poor little chap up at the end of the queue has been there for an awfully long time. So if you can try and get the sperm that have just joined the queue, they may have better DNA fragmentation and therefore a better outcome. But we come back to the difficulty with fertility research, because so-called research, because to prove that what I have just said is true is almost a life's work, because you have to then match those couples for their particular circumstances, the age of the lady, and many, many other circumstances. And then you have to follow the couple up to live births and get the data. Because if you're looking at 5, 6, 7% improvements, then you need large numbers to be sure that that is actually true, and complete data. And I'm sure Carole will know, you would think that getting complete data from couples who have gone to one place for one intervention would be easy. But it is extraordinarily difficult, extraordinarily difficult. And if you add to that the research bias that is in all of us, so those who review research papers will tend to go on promoting the ideas that they had 20 years ago. Very difficult to get even a clever person out of that rut, to look over the parapet and say, this just might be right. Let's just publish this. Let's just float it out there. It doesn't really happen. We tend as doctors, particularly, to go on bashing the same drum.
But certainly the last 2 years, we've done some very exciting work, and I know Jonathan's worked with a number of different centres, but certainly, you know, we were just finding patients coming back for repeated cycles of IVF and failing, and we were scratching our heads. And lo and behold, when we started measuring DNA fragmentation levels, there were some patients with extremely high levels. And we started to look at why they might be high. And one of them, which we're really still exploring, is the microbiome. So the bacteria, the good and the bad bacteria, which we're also exploring in the female. But in the male, it seems to be a significant factor, and trying to look for infections that don't cause symptoms, but actually do cause a lot of genetic damage in the sperm, and then treating those infections, putting in probiotics. And we're doing the same with women, and getting that perfect situation. So not just saying, well, look, we're just going to do another cycle, actually making a difference. And we've had some real successes. And that's where, you know, we've even taken it a step further when we found that we've put in these interventions, we've put some antibiotic treatment in, but the DNA fragmentation hasn't budged down. And then you're doing some very interesting work with actually doing a sperm retrieval on men who don't have azoospermia. They have sperm, but they have high levels of DNA damage. But as Jonathan was saying, if you can extract the sperm directly from the testicle and then use it in an ICSI procedure, you're getting some really interesting outcomes. I'm sure there'll be some patients watching this that have had those outcomes. It's quite an area of cutting edge fertility medicine.
But you do have to be very careful, because as you go closer to source, i.e. to the testicle, then whilst the sperm may be less affected by what might later happen to them as they travel through the genital tract, so as they emerge from the testicle, go through the epididymis, up the vas, through the prostate. Although if you take them from the testicle, those sperm are not going to be affected by some inflammatory process, for example. Nonetheless, they may be less mature.
Mm-hmm.
So you do have to be extremely careful about this. And what we're doing at the moment shows that maybe 10 or 15% of those who you might have thought would do well with this actually don't. And the only way you can try to measure the efficacy of those sperm is to do quite sophisticated fragmentation tests on the sperm that you retrieve, rather than just saying, oh, we've got the solution, we'll just do this. And it's very easy to fall into that trap with couples who may have failed 3 cycles, to offer them something, anything to change the scenario, as Carole's saying, is attractive not only to them, but to us, because we're pretty needy too. You know, we want to say yes, we want to give something more. So it's very easy to grab onto almost anything. But to measure what it is that you're doing as well as doing it is, I think, very important. And it's difficult to do that because it's time consuming and expensive.
Absolutely. It's interesting what you said about the maturity of the sperm if it's found within the testicles. When my husband had microtessie, the surgery lasted for 5 hours. So we knew, waiting that probably wasn't a good sign. And the doctor had gone into both testicles. Hopefully he won't mind me talking about this. But they did retrieve sperm tissue, I believe, and they watched it in the lab overnight, but it was not going to be good enough quality to fertilize my eggs. So we found out just before my egg retrieval the next morning that we would be using the donor sperm that we had ready. So there was not much time between having that 100% no genetic children for my husband to we're using the donor sperm that you had bought as backup sperm, as it was referred to. So do you find that patients often like or need to have a break between this kind of procedure and then moving forward with a cycle? Or do you think that people move ahead straight away with other options sort of ready to go, if you like?
It's all about making the patients work with you and understanding what your expectations might be, and for them to share those expectations. And the counselling in medical consultation is really, really important. And I think we both prepare patients. We talk about the backup donor sperm, and for me, it's mandatory, particularly for the person that might be the non-bio dad, to get counselling at that point, to get that implications counselling for the what ifs. Being prepared for the worst case scenario is, and it's not mandatory, but it is so important. If you don't do that, I think, yes, to be thrown and jumping in on day of egg collection to that decision is the wrong thing to do. And now I always say to patients, there is a cost to it, but consider freezing eggs if you're not 100%, because we know that egg freezing techniques are much better than they were 5 years ago. We've got results. We know that we can use eggs.
I think it can also depend on the couple or the individual, can't it? Because I was just in this sort of headspace of devastated that my husband and I would not be able to have biological children together. However, we had been through so much at this point. We just wanted to have a baby, and so I was ready to go, and he wasn't there yet. So when the first cycle failed with donor sperm, he was actually quite relieved, and it consequently worked the next cycle a couple of months later from the same embryos that were frozen. And so he needed those few months to get his head around the option that we were going for. But knowing and loving our children now, I find it strange to sort of think of that as a backup option, because we obviously that's our life now. And so you're right, counselling to understand how the family is going to be and how that might play out for every aspect of life is so important, isn't it? Rather than rushing a decision. I'm not saying we rushed a decision, but rather than not having all of that information to hand when you're in that moment of just wanting to get pregnant.
Sure. No, I think Carole's words about preparation, about trying to slow the process, about involving others in this process, it is absolutely vital. There is an underlying psychological problem, I think, with the human brain, all of our human brains, because when we're dealing with fertility, it is, after all, binary. It is baby, no baby. It is joy, it is misery. And then when you translate this, particularly for men who do numbers, into sperm, no sperm at a sperm retrieval, where after all, in most circumstances, not all, but in most, it's 50-50. So there's another binary problem. And to ask, what is the chance of finding sperm in a microtesy? 50%. That is to ask the wrong question. Mm-hmm. Is completely the wrong question. The right question always should be, are we going to have a baby? Now, even that, we go back to 50-50, and with human nature, a little bit of optimism, all couples are going into all procedures with a sort of hidden 50-50 agenda, bit of optimism, it's 60%, we're going to make it, as opposed to something completely different. And as Carole was saying, this is largely about our attitude, but it is fighting that 50-50 all the way. It is bringing down that expectation in the kindest, most careful, most reasoned way. And it may take 3 or 4 consultations and other people to get to that point, so that we don't, at whatever point in this, fall off a cliff edge and say, but this is dreadful. You know, I wasn't expecting that. How often do you hear, I was shocked? Well, if you've been properly prepared, you know, 50-50, there's nothing shocking. And if it's worse than that, as it often is, 80-20, and you know, you're in the 80% failure, well, it shouldn't be shocking. And I think it behoves us to do everything we can to prevent that.
Yes, absolutely. And you know that when we talked about the counselling, I felt really compelled to share that over the last year I've seen our counselling, the use of our counselling service really increase. But more importantly, increase where men have come forward and said, do you know what, I'd like to talk to somebody. And I think it's really important that guys now are coming forward and saying, I feel hurt by this. I know even if they haven't got a fertility issue, I feel hurt by the fact that we can't, as a couple, have kids. And they're actually acknowledging that they are feeling sad, depressed, whatever it is about the fertility process. Whereas before, I'm sure they were feeling exactly the same way, but it wasn't cool to talk about it or to acknowledge that they had a problem. And it's really lovely that we are now getting more and more men actually coming forward and saying, can I talk to somebody? And on their own often. That's so important, because I think even if you have sperm and it's an ICSI sample, and as a result of that you have to go through ICSI, you know, the guys feel guilty. They feel that it reflects in, you know, in everything they do. They're worried about it. They feel bad about it. It affects their sex life, and it's so important to just go and talk and actually realize this is okay. You know, in the old days you wouldn't be even able to have a biological child, but now we've got assisted conception, and there's no fault, there's no finger pointing in fertility. It's a couple decision to come through for treatment, and you kind of share that pathway together. There's nobody at fault, you know.
We, my lot, and particularly I think probably my lot, who are often giving these diagnoses, often entirely carelessly. We know not what we say, and we don't understand the consequence of telling a man that, you know, he's got 2 million sperm and they're not swimming very well, and actually the morphology isn't very good either. I mean, this is devastating. This is bang, bang, bang. And from that moment on, life changes. And we don't realize that. This is almost equivalent, and I would say sometimes worse, than a cancer diagnosis to a young man. Because to say there are no sperm is a bit like saying you've got a tumor and we can't treat it. And we can't treat it. That's it, you know, end of story. And we don't appreciate that. I think it's largely my generation's fault, because we were in a position to teach the medical students so that the general practitioners would understand how devastating this is, but we haven't really. And the number of times you and I will see the devastated man. Now, as Carole was saying, an awful lot of the others are devastated underneath. But the effect upon the relationship, the effect upon their lives of this careless, casually given news is really awful. And we need to address it. I think before Carole and I stop practicing, perhaps we ought to go out on the road and do general practice. And
well, I am going into companies and doing talks about fertility, and I do bring out, you know, but you know, companies ask me to talk to educate their staff about fertility issues. And it's really surprising. It's 95% women who attend. And I think there's a general lack of education in the workplace, but also in not in general practice, but also the NHS pathway is very difficult to access. Proper NHS pathway to full investigation of the male. I think only a fraction of people actually get to you.
Oh, crikey, it doesn't exist.
Yeah.
And that, of course, is a problem. There are many, many benefits of socialized medicine, and we're far better off in this country than many countries, because fertility units can be accessed by most, not all, but most people. But of course, the consequence of that is that there is only one pathway, and there are only some very simplistic gateways. The gateway may be 2 years of trying, it may be body mass index, it may be age, but actually it doesn't have anything to do with the medical condition, which is male infertility. So these guys are nowhere, even when they've been referred, because everything has to do with a few criteria, none of which have anything to do with him. Nothing at all. And then, not here, of course, but in 90% of units, those men will be managed, in inverted commas, by gynecologists who, after all, did take a decision when they were 20 that they were never going to see a man. That was in the spirit of the event. So they are in a place where they are liable to be emasculated anyway.
But I think it's also not just in the medical field, it's also within friendship groups and families and communities where it's not really spoken about very much. People make comments and jokes about masculinity and jokes about shooting blanks and things like that. But for people who are affected by these things, those kind of flippant comments are very hurtful and don't do a lot for confidence after going through such a thing. So I think also it's great if men can talk about these things, because a lot of people don't.
I think the narrative is changing about talking about embarrassing problems anyway. I think people are, I mean, we've just seen, the last 6 months, I've seen a lot more openness about the menopause, for example. So I think if people are able to talk about the menopause and how awful they feel going through it, and they're able to talk in the workplace about it and with family, I think it will not take too long to start being very comfortable talking about, well, I do have a sperm problem, and let's go and have a pint and talk about it. And I think that's a really healthy thing to do.
Especially as the whole world has a sperm problem.
Yes.
And
it's getting worse.
Yeah. So thank you both so much for your time today. I feel like we've discussed many things. What would your advice be to someone who is starting out the process, wondering about testing or where to go and kind of what route to take?
Carole.
Well, I think most clinics now run very nice fertility MOTs, and I think whatever you're going to call it, it's a basic test of the female, test of the male that will give a couple an idea of where they're at. And I would run that if you haven't conceived within 6 months. Just go along and run it, because you'd be surprised. Even somebody young, female may have an issue, male may have an issue. Why waste 2 years before you do that? They're relatively accessible. Yes, I know the GP won't do it for you. And if after a year you haven't had the finance to do that, the GPs should be starting to investigate both the male and the female with a semen analysis for the male. And then sort of look around, shop around, because you can do with just getting an idea of where you should be going, and a consultation with a fertility expert, if you can't get there through the NHS, is well worth the money. Just a consultation, isn't it? Just to get, well, should we try for much longer, or is there something seriously amiss here? And with that, you should get the package of some proper fertility counselling. And then it's people like yourself, Eloise, you're doing a great job in educating people. And I think the social media platforms and educational fertility hubs like you are a good place for people to go to for just peer support, if nothing else, realising you're not on your own. 1 in 5 heterosexual couples will need help at some point to conceive.
Absolutely. And I was delighted to have this conversation with both of you and with yourself, Dr. Ramsay, because of my personal story. We get DMs from people on a daily basis, most often women coming forward on behalf of their partner, but just saying, this is the diagnosis or this is where we're at and we just don't know where to go now. We feel as though life has stopped and we can't see a way forward.
Well, so just to go back one step, there is one thing that I would be wary of, and that is the home sperm test.
Mm-hmm.
Now, there are two reasons. The first is that if a person is seeking information on such an important issue without that information having been asked for by somebody who could respond, then when that test is unfavorable, then there is nobody to turn to. And I have seen many men who either openly or secretly have been testing themselves every 2 or 3 days because they had an abnormal test and are getting more and more worried and more confused and quite obsessed with this.
Mm-hmm.
Now, of course, at one end of the OCD spectrum, I'm sure you've had patients, I've had patients who bought themselves microscopes.
Wow.
Looking at their own sperm. This is not, believe it or not, uncommon.
Wow.
But the second reason, the first reason I countenance against doing the home kit is because there's nobody to explain it or discuss it with. But the second is that these are not entirely reliable. And the circumstances of doing it may reflect what has been happening to the man 2-3 months before, even. And so I think that we get off to a worse start, in my experience, with home testing. We get off to a better start if somebody has requested the fertility MOT, if the GP has requested it, because at least then there's a fallback position, and it's not instant. You know, we all know the effect of the instant pregnancy test, you know, joy, misery, binary. It's the same with the home, or maybe the same with the home sperm test. So
just to add, at the Agora clinic, we introduced during the first lockdown the home test in the context of an MOT where the man didn't want to attend the clinic, or just didn't want to. It gave us an indication, and we put it in that, you know, this is an indication. This is not as accurate as a lab test, but we go through the test with them, and if it's bang in the middle of the range, normal, it's reassuring.
Yes.
But if it's low, we would always bring them in. And so it's not as a sort of standalone test that you do yourself, just as you say. I wouldn't recommend it, but in the context of a consultant-led fertility MOT, it can be a useful tool to avoid. And do you know what? It's quite nice because men are often quite hesitant about coming to a fertility clinic. So it gives them a halfway house where they'll do a test without having to, you know, go in, which is a bigger step for them to take.
But that is
you need the support.
So
yeah.
You want the support afterwards, just in case the results aren't favourable and you need some questions answered.
Yes.
Brilliant. Well, thank you both so much for your time today. It was such a pleasure chatting with you.